All right. Thank you again for having me. It's really exciting to get to share some exciting news and breaking news in HS. So, for those of you who don't know me, I'm Dr. Lauren Lamb. I'm a dermatologist specializing in HS and HSC roofing, practicing in Calgary. And I got the chance to go to Milan in September earlier this month, where really you could feel the buzz in the air was all about HS, which I've never actually experienced before that. All the other dermatology conferences that I've gone to, most of the buzz is usually around psoriasis and psoriatic arthritis. And in the last few years, well, I guess the last 2 years we didn't get to go in person to conferences, but I've really felt a shift. And the main highlight this year in Milan was HS. So the big pièce de resistance was on the very final day. It was in a session called Late Breakers, where they released phase 3 clinical trial data on a new biologic in HS. So that biologic is Secukinumab. For those of you who know by the brand name, it's called Cosentyx. It's an IL-17 inhibitor, and it works in a different pathway than the TNF alpha inhibitors that we know are the only approved biologic right now for HS, called adalimumab, whether it's biologic or biosimilar. So the trial showed that with two types of dosing that they were testing, they were basically testing one dose that's every 2 weeks and then one dose that's every 4 weeks. So both of them showed superiority to placebo. And then they showed something called a high score meaning you have a reduction of AN counts or abscess nodule counts by 50%. It showed about 45% of patients were able to achieve that with both doses, a little bit higher with those patients on the every 2 week dose. So it's, for those of you who aren't familiar with AN or aren't familiar with those scales, it's an easy way to try to compare one treatment to another, although it's not perfect because it's just a snapshot in time. But if you were ever enrolled in a biologic or for a biosimilar, at baseline, someone would have done a score where they would have counted every last abscess, nodule, scar, tract, or draining fistula on your body. And then 3 months later, we do that same count again and we see how much of a reduction there is. So if there's a 50% reduction in that number, then that's considered a high score 50. So basically, this trial was showing that Secukinumab, this IL-17 inhibitor, works about the same in terms of improvement in that score as adalimumab. So, you know, the buzz I'd heard before that was maybe it would be a little bit higher than 50%. So that's still a win in my mind because, number one, as you guys may be aware yourselves, not everybody gets a sustained improvement from adalimumab, right? Some people get some improvement, but over time it needs to, you need to add more agents again. And then some people completely fail it at some point where it's not really doing much anymore. So this really offers a second biologic treatment for those patients that have failed adalimumab. Mike, I see you have a question.
No, I was one of those patients who failed.
Exactly.
I can't say that word.
I have a question. Was this data just on medication alone, or was there data on like combination therapy with the drug?
So
as in like surgery and...
Yeah. So these patients were allowed to continue oral tetracyclines or oral antibiotics, but otherwise they weren't allowed to continue on anything else. Because usually with phase 3 trials, you want to show that the medication alone is what's doing the job and not all these other ancillary things that are working as well. So I also think it's a win because, as you may or may not know, there are some contraindications to adalimumab. So people who have CHF or MS or lupus, they all technically can't take this medication, adalimumab. So I do have a few patients that fall in that category, which I never thought anyone would be unlucky enough to have two conditions like that all at once. But this would be a great option for those patients, for example.
I do have a question. Is it like I can say that word again, where it's a shot, or would it be more like an infusion?
Yes, so it's also an injection. This is a medication that has already been studied in psoriasis and psoriatic arthritis, and these are the same doses that they're using in HS as psoriasis. At Q2 is a little bit, or every 2 weeks is a little bit more frequent, but they are injections rather than infusions.
Cool.
Go ahead.
No, I was going to say, I went to a skin summit last weekend, and one of the dermatologists said, we have thousands of different types of diseases we treat, but we really only have 50 medications. And, this is where off-label comes in hand in dermatology, because you guys kind of have to play around with what you have and, look for comorbidities or other things to be able to get access to different medications. So it is nice to have another option out there as well for folks, like you said, who have lupus or, didn't do well on a TNF blockers. Now they can go to, what was this? Is this an IL-17 or 23?
17.
17, okay.
Yes. I mean, there's other advantages too. So every 2 weeks instead of every week, which I'm sure any person who's getting poked every week would appreciate being poked fewer times. The one thing that is something to consider is that we know that inflammatory bowel disease can also run hand in hand with HS. So it would not be for a patient who has Crohn's or ulcerative colitis disease, because that's the one real contraindication for IL-17. But we did notice that it actually has faster onset than adalimumab as well. So that's another bonus, I think, to having this additional treatment for HS. So this was a phase 3 data. So they will still need to do phase 4 clinical trials where they really open it up to thousands of patients. But so far, it's looking really good. I think the other thing to keep in mind is this trial took very severe patients. So, that is something to keep in mind, that they weren't just cherry picking well patients to begin with. They were treating some very severe patients as well. Crystal,
I have another question. Were they choosing patients that had been on, failed adalimumab and then put on this?
Yes.
Okay.
Yes. So I think that those are also things to keep in mind. The number maybe is, well, I wouldn't say disappointing, but we were really hoping for something more than 50%. But I think keeping in mind with those other factors, it still is doing well. And of course, it's just a landmarker in general that we have another biologic for HS potentially coming down the line. Some of the other really interesting things that they talked about at the conference was that they talked about the fact that, I think we could have guessed this anyways, and we have started to understand this about other dermatologic conditions such as psoriasis and psoriatic arthritis, but they actually demonstrated that in HS, patients actually have an increased amount of inflammatory markers, period, compared with patients who don't have HS. And that's one of the thought processes behind why there may be so many new treatments coming down the line eventually, is because all the inflammatory markers are raised in HS. Something else they mentioned too was that there's been a lot of publications about things like phenotypes. So I don't know if you guys have also experienced this anecdotally, just chatting with one another, but I have noticed that there seems to be two general phenotypes, or two types of HS patients. One type seems to be the patients that have more like the blackheads, more follicular-based, almost acne-looking like lesions. They're usually a little bit less severe and tend to be more responsive to things like topical keratolytics meaning like topical vitamin A, for example, or oral vitamin A. And then there's the other phenotype or type of patient where they tend to be a little bit heavier, the lesions are more severe, more inflammatory, angry, like baseball size types of flares. And of course, we know that those patients are a little bit more difficult to treat because it is more severe. They haven't found a way to make all of the coherent way to use the information with these types or subtypes of HS. But I think for practitioners, it is helpful to note that in your mind because you know that some patients you should, like the inflammatory patients, you should probably be a biologic sooner because they're probably going to be more likely the severe type. And that way we can prevent scarring, for example. The other things that they did. Go ahead.
Oh, I was going to ask, do you guys screen your patients for comorbidities when they come in, like depression, for example, or like arthritis? Like, do you guys screen for some of that stuff, like some of the major comorbidities when you get new patients?
So I think it really depends on the practitioner. I do. And as you guys know, Dr. Pullman, who's the president now of the CHSF, she is implementing easy screening tools that just populate into our EMRs so that this is an automatic question that's screened for. But I would say it's very inconsistent at this point.
Yeah. And like if somebody said, like, just because I know it's different in province by province, but like in Alberta, where we are, for example, if a patient did have, depression and asked for to see someone for mental health, would that be able to go through you, or does that need to go through a GP? How does that get handled?
Again, I think that's going to be practitioner to practitioner dependent. Our clinic, we have actually partnered with Co-op Pharmacy. So the pharmacists are well informed about HS. And so if we note that there are some ancillary things that need dedicated time, for example, screening for depression, wound care, discussion about low inflammatory diet, or even zinc supplementation, we just refer our patients to Co-op Pharmacy and they can do some of that for us, even smoking cessation. So I think for the experienced HS dermatologists, they can definitely facilitate some of that or have some things already put in place so that that doesn't get missed. If you're seeing someone at a tertiary center, meaning like an academic center, so associated with the university, they probably have more resources that they can refer you to. But if not, then I do suspect it would have to be through the family doctor. But, the family doctors clearly have lots and lots of support at their fingertips that they can refer you to. I had a few other points. So this is more practitioner based, but just interesting maybe for patients to know. So they did do some studies to look at whether or not the combination of two antibiotics that are occasionally used together in HS, clindamycin and rifampicin. Usually we kind of reserve that for patients that are more severe, but they've actually looked at the comparison between that and doxycycline. That's usually our go-to easy first step antibiotic. There haven't been much improvement between the two. So they saw that both seem to be quite equivalent to one another. And of course, clindamycin and rifampicin is quite a very heavy duty regimen. Clindamycin does run a risk of creating something called C. diff. So you can get some pretty major side effects in terms of developing ongoing diarrhea with the clindamycin. So it is just good to know that the doxycycline is just as effective as what we consider to be step-up therapy. So I think that's good to know because it's safer and more tolerable compared to clindamycin and rifampicin.
That is good to know.
Yeah. And I guess one more plug for me. not for me specifically, but for deroofing. Again, they were showing videos of European techniques of deroofing where they essentially use a loop where it runs some cautery through it. So what they do is they freeze the area, they just sort of draw out where they think they want to remove, and then they use the loop and remove that tissue. If you Google deroofing, that's actually what comes up first, which I think is a little bit scary for patients because it's meant for physicians, so you can see what the whole surgery looks like. But at a different conference that I went to earlier this year at SPIN in Paris, one dermatologist presented his collected findings, and he said that he had about a 22% recurrence rate, which is actually a lot higher than what I've noticed in my own personal practice using the technique of using curved scissors and really following all the tunnel tracks. I would say honestly, I could count on one hand the number of patients that I've had some recurrence using this technique. So just eye-opening, I think something, a good point of discussion amongst dermatologists to see what works best and what makes the most sense in terms of people's practices. I think for some people it might be more efficient to just do the electrocautery one because I think it's less time consuming. But they did have a lot of bleeding complications being their number one complication. So I haven't experienced that personally. So just interesting to note worldwide differences.
Is that similar to the punch technique that you were talking about, Steph, the other day?
I think so I had mentioned that in 2019 Dr. Syed had talked about how instead of doing incision and drain, he uses a punch tool to create a small hole so that it stays open a little bit longer and drains a little more easily. And Dr. George in our next podcast episode or last podcast episode, depending on when you're listening to this video, talked about how he actually does like using a punch tool, which he then uses as his initial point of insertion when he's doing a deroofing surgery.
Cool.
I think it's a little bit different than the loop tool that's just cauterizing and burning away the tissue.
Yep. Different.
Does it show how strange that I am that when you said the loop tool, I was picturing lassoing an HS boil?
It pretty much is. It's like a firm loop that you just you're just lassoing out the tissue off, basically. Dr. George is actually coming to Calgary to give us a talk for the general surgeons and the plastic surgeons in Calgary. We're hoping that that's really going to help facilitate better handoff and partnership with the surgeons in Calgary. I think you guys have been so blessed in Edmonton to have surgeons that are really on board and up to speed and understanding of these new techniques and new understandings of HS. So I'm really looking forward to that. I'll put that in there as well. It's October 27th and 28th that he's coming to Calgary to talk.
He told us he's really excited that he's going to Calgary and that he's going to see Dr. Keeling and all the people. So
yes, exactly. So yes, Dr. Keeling is coming for our talk as well. So.
Has it been approved by Health Canada already? Is it on market, or are we still waiting for it to go on market for HS?
So we're still waiting for phase 4. So every medication has to go through 4 phases of clinical trials before they're approved. Hopefully they'll be approved just as quickly in Canada as it is in the US. Sometimes we get it approved sooner, but most of the time we get it approved a little bit later than in the US. So I think their phase 4, I don't know if it's already on the way, but usually once you have that, again, more positive results, confirming your results, that's pretty imminent after that. So.
Okay, neat.
Yeah.
I wonder if, while we're talking about clinical trials, if you can maybe explain to us a little bit how side effects are listed for drugs like this, because our understanding is people within the clinical trial, whether on a placebo or the actual drug, whatever side effects they experience are listed as side effects of the drug, whether they're on it or not. Is there truth to that?
Yes, so it's very, very rigorous when you're in a clinical trial. Any last little side effect that you might experience always gets logged and reported, whether or not that's related to the medication, whether or not you're on placebo or medication. So sometimes you'll see, for example, a upper respiratory tract infection is usually the most commonly reported side effect that's significant for most biologics that we're talking about in dermatology. And then when you look across treatment arms and placebo arms, they're usually quite similar to one another, which tells you that it's probably not related to the medication per se, if they're quite similar across. So the one side effect that we also think about as dermatologists with the general group of IL-17 is candidiasis. So it's not fulminant, not threatening in terms of your life, or not a major complication. But usually people do, if they are going to experience candidiasis, they may experience a few white plaques in the mouth or in the genital area. Those are very easily treated with oral antifungal treatments or swish and spit medications, and basically you continue and treat through that.
So is the layman's name for that thrush?
Yes, thrush. Exactly.
Okay, that's why. Yeah. Sorry, thank you.
Exactly. Yes. So they noted in this trial that about max 2.6% of patients developed candidiasis. So, that's not a high number, and that's within the expected range, especially considering what we have seen in psoriasis before with these similar doses. So just good to know that there weren't any unsuspected, or what am I trying to say here? There weren't any unexpected side effects.
I think patients hear side effects and don't understand that it's more like severe outcome that's more scary with that. And I know I've had someone tell me that somebody broke their arm one time while in a clinical trial, and that had to be listed, right? And I think do you guys still report stuff after a patient starts the medication? And if there is a severe outcome, you report that to the company and they mark that as well?
Yes, so that's called post-marketing research, and we do essentially inform the drug company, and they also keep tabulations on that. So they have something called real world data, where they look at 5 and 10 years out after the medication's been on the market, and they compare that, for example, to what it looked like in clinical trials, and whether or not there's any significant, what they call them, safety signals, or essentially any unexpected safety outcomes that came out of that.
I was going to just ask one more. Do you find with your HS patients, I've heard, the number one complaint if you've got patients with psoriasis or AD, that it's I'm itchy. Do you find with HS patients the number one complaint is I'm in pain?
Yes, that's the equivalent, I guess you could say, in the disease states. Pain is definitely the number one concern.
Are there any studies? Were there any studies addressing pain and pain management?
Yes, they actually looked at pain in this study as well. So they got patients to do something called an NRS score. Basically, just tries to quantify your pain, and they did show a significant reduction. I'd have to double check, but from my memory, it was about 30% reduction in those pain scores, which is quite significant, actually.
And
you guys could tell me best.
I have one more question. It's a little off topic, but I had a patient ask me if she wanted to start a biologic and stay on it, or a biosimilar, for a couple months, and then go off, and then go back on it for a couple months. And I was just wondering if maybe you could explain to patients that why these are long-term medications, and the complications of just taking it for 2 months and then going off and taking it again.
Of course. So these medications we think of them as long-term medications because, as you guys have probably experienced, HS is ongoing, long-term, chronic. As you noticed, also, it takes a few months for the medications to really kick in, which is why we assess you at 3 months. So if you were to take it for 3 months and then stop it, you would probably lose a lot of the efficacy that you are slowly working towards in that 3 months, which that's why you have that, what they call a loading dose at the beginning, where you get a whole bunch of shots at the beginning. That's because we have to get to a certain level that is actually in the body before, and then those continual doses that are every week to maintain that level in the body. We've also seen in psoriasis that if you stop the medication and then you try to restart the medication, you often lose efficacy, or you lose how well the medication works. So it might still kind of work, but we've seen in some patients that it doesn't work to the same degree that it did when you were previously on it. The thought is that maybe you may be building antibodies to the medication itself while you stop the medication. So given that, in HS, we only have one biologic option, it's probably not the best choice of actions in probably a lot of healthcare practitioners' opinions to be doing stop, start because of that. In psoriasis, we're lucky we have 12 options to choose from. So if you lost efficacy from one medication, you can always try another. But I think in HS, we don't have that luxury at this point in time. So ideally, you would stay on it. I would say at least, I want to see my patients doing well for at least 6 months before we consider any kinds of changes. But to be honest, I've found most patients, they want to stay on it because they finally have their life back, they're feeling better, and they don't want to stop because they want that to continue.
Yeah, I always feel like this is a medication I'm going to be on for the rest of my life, just like people who are diabetic take insulin, like to keep them alive and healthy. And I just feel that's why when I say long term, I guess I can't speak for everyone, but I know probably out of the other two, they're in the same boat as I am, where we want to stay on it because we want to stay where we like as healthy as we are right now.
Exactly. That's actually how I usually frame it, that HS is chronic and ongoing. So like brushing your teeth, you got to do it every night, right? To make sure that you maintain your oral hygiene. It's the same thing.
Did they mention anything about, I know we got to let you go right away, but did they mention anything about, what is that new medication that's come down the pipeline lately? It's a pill that you can swallow. I had JAK inhibitors. Yes. Did they mention any with HS?
Yes, JAK inhibitors are another group of medications that are being studied for HS. There's some preliminary data, but now I'm almost hesitant to mention it because some of the other preliminary data had looked really good for some of the other medications, and then have fallen by the wayside a little bit. So JAK inhibitors is one group. There's IL-1 alpha receptors is another group. IL-36 is another group. There are medications that are targeting complement pathways. So there's actually lots coming down the pipeline. It's just waiting a game, I guess, to see.
So in 5 years could be kind of a different sort of world for treatment.
I think so. Especially, I think companies have now realized that HS is an important area to really focus on. So, for example, there was a new psoriasis launch. I think it was this year. Bimekizumab, which is also an IL-17A and F inhibitor. So they've already started on looking at their efficacy in HS, and it's also looking really, really good because they know that HS is going to be an important landscape to change in the future for dermatology. So I think things are really starting to pick up because they understand that this is the next area to really focus on.
Sounds kind of exciting.
Yeah, really exciting. Well, if you guys don't have any other questions, I just want to thank you guys again for having me. I think it's really, really important that we have channels for patients to relay this information, because it's well and good that I know that and all my colleagues know that, but it's important for you guys to have hope, right, for the future, and to know that these things are coming up so that you know what the next step is. If you've not done well on adalimumab, that maybe this will be an upcoming treatment for you. So I want to thank you guys for reaching out and allowing me the opportunity to share that information.
I really appreciate you coming on and doing this, because like I say, I watch all these conferences like a dirty shirt, and I try and get us access to some of them, but like, I get it. We don't want patients in there all the time. So it's so nice for you to come on here and fill us in, because, there's only so much I can see watching through tweets and what other people share. So we really appreciate you sharing with us.
I think it's really opened my mind. It's opened my eyes to even just having this time with you guys to realize how oftentimes we are more focused on our side of things in terms of this type of information, and how we need to get that information out to you guys really. So
Patients want to know too.
Of course.
And we want to help build the trust, right? So,
yes, absolutely. It's interesting. I tell my de-roofing patients that have had a good experience, I tell them to actually post, not for my sake, but for each other's sake, because I know that there's less trust in physicians in the HS community, understandably, because of everything that you guys have gone through. So I understand that the trust really comes from each other, because you have to trust each other in what you guys have experienced. So,
well, and we know, what these medications can do. So we really want to be able to have patients come to you and see our success and know that they can have the same success as well, and that there's other options. There's more options than ever for them.
Of course, and still coming.